Mark your calendars for RSNA 2025, Imaging the Individual. In Chicago, November 30th through December 4th. Join medical imaging professionals from around the globe to explore a future where every patient is seen through a lens that honors their unique genetic makeup, diverse background, and healthcare needs. Discover innovations that help us advance the future of medical care for all. To get the latest information about RSNA 2025, go to rsna.org/annual meeting. Registration opens late July.
Hi, my name is Katie Epstein from Cincinnati Children's Medical Center. Welcome to the RSNA RadioGaphics podcast. I will discuss the RadioGaphics article entitled Anatomic Approach to Fetal Hydrocephalus by April Griffith and colleagues. Hydrocephalus refers to the greater than expected volume of cerebrospinal fluid, CSF, in the calvarium relative to the amount of brain parenchyma, and it is a vague term. The more precise and preferred terminology is ventriculomegaly, enlargement of the ventricular system. The incidence of ventriculomegaly is 2 in every 1,000 live births. Appropriate measurement technique is paramount in order to diagnose ventriculomegaly and subsequently grade its severity. There is a broad differential diagnosis when ventriculomegaly is encountered with variable outcomes. Hence, it is important to accurately differentiate the underlying cause of ventriculomegaly to help guide patient counseling and management. This article utilizes an anatomically based approach in the evaluation of ventriculomegaly to help narrow the differential diagnosis, with assessment of the posterior fossa, midline structures, and cerebral mantle. First, we will briefly discuss the ventricular anatomy and appropriate measurement technique and why ventriculomegaly matters. The ventricular system is composed of the paired lateral ventricles connected to the single central third ventricle via the foramen of Monro. This is connected to the infratutorial fourth ventricle via the cerebral aqueduct. The lateral and third ventricles are best assessed on the standard axial view on fetal ultrasound. However, the cerebral aqueduct and fourth ventricle are best assessed on the sagittal view. Fetal ventriculomegaly is defined as the lateral ventricle diameter equal to or greater than 10 millimeters in size, and can be graded as mild, moderate, or severe. The width of the dependent lateral ventricle at the level of the atria is measured perpendicular to the long axis of the ventricle at the level of the parietal occipital groove, with mild ventriculomegaly defined as the lateral ventricles measuring 10 to 12 millimeters in size, moderate 12 to 15 millimeters, and severe greater than or equal to 15 millimeters. Ultrasound remains the preferred modality for accurate classification, and measurements on MRI may differ from ultrasound by 1 to 2 millimeters. However, fetal MRI can help detect additional findings not seen on ultrasound in up to 23 to 50% of cases. Variable prognosis is associated with fetal ventriculomegaly, with isolated mild ventriculomegaly, a diagnosis of exclusion, associated with normal neurological outcomes more than 90% of cases, with neurological outcomes good in 75 to 93% of cases of moderate ventriculomegaly. However, postnatal follow-up is essential, given that 10% of fetuses diagnosed with isolated mild ventriculomegaly are found to have structural abnormalities in the postnatal period. Utilizing an anatomy-based approach in the diagnosis of fetal ventriculomegaly can help the radiologist narrow the differential diagnosis to ultimately guide prenatal counseling and management, as outlined by the authors. Based on their strategy, the posterior fossa should be assessed first before the assessment of the midline structures and cerebral mantle. If there is not obstruction at the level of the posterior fossa, then midline structures are evaluated with subsequent evaluation of the cerebral mantle. The diagnoses that involve obstruction at the level of the posterior fossa that we will discuss include aqueductal stenosis, Dandy-Walker malformation, and Chiari-2 malformation. Starting with aqueductal stenosis, which is the most common cause of prenatal obstructive ventriculomegaly. Most cases are sporadic, although aqueductal gliosis or web formation can occur secondary to infection or hemorrhage. Aqueductal stenosis results in moderate to severe enlargement of the lateral and third ventricles with funneling of the third ventricle. The fourth ventricle is normal in size. The midline structures are intact, although callosal thinning is seen secondary to obstructive physiology. 10% of aqueductal stenosis cases are associated with rhomboencephalosynapsis, in which there is fusion of the cerebellar hemispheres with variable Vermean hypoplasia. An important syndromic cause of aqueductal stenosis is X-linked hydrocephalus, caused by an L1CAM gene mutation, a hallmark finding in male fetuses as adduction of the thumb seen in 88% of cases. Additional findings that can be visualized include dysplasia or hypoplasia of the brainstem, pons, and vermis, and variable callosal anomalies. Next, we will briefly discuss Dandy-Walker malformation, a range of structural abnormalities of the cerebellum and posterior fossa, secondary to lack of fourth ventricle fenestration and failed formation of the rhomboencephalon. Imaging features of the posterior fossa that trigger prenatal and postnatal assessment for Dandy-Walker malformation in the fetus with ventriculomegaly include hypoplastic or aplastic vermis with increased tegmentovermian angle, enlarged fourth ventricle and cisterna magna, and elevated torcula position. Chiari-2 and 3 malformations are also associated with fetal ventriculomegaly and are characterized by hindbrain herniation with effacement of the sterna magna. Incidence of Chiari-2 malformations are 0.5 to 1 in every 1,000 live births. Findings on fetal ultrasound include a banana configuration of the cerebellum as it wraps around the brainstem, with effacement of the cisterna magna CSF space, and a lemon-shaped head with bifrontal concavity. Ventriculomegaly is seen in 45 to 90% of fetuses with Chiari-2 malformation in the second trimester. Fetal MRI is a useful tool to quantify the degree of hindbrain herniation and to assess for possible additional abnormalities in the fetal brain or body, such as callosal agenesis or dysgenesis and cortical heterotopia. Chiari-2 malformations are associated with open neural tube defects, most commonly in the lumbar spine. The management of myelomeningocele study, aka the MOMS trial, demonstrated that in utero open neural tube defect repair before 20 weeks gestation led to improved ambulation at 30 months postnatally, improved or resolution of severe hindbrain herniation in 89% of cases, decreased need for ventricular shunt placement. However, ventriculomegaly was not significantly different between the pre- and postnatal repair groups. However, chorioamniotic separation, uterine dehiscence, and preterm labor were more likely in the prenatal intervention group. Next, in the evaluation of fetal ventriculomegaly, if there is no obstruction at the level of the posterior fossa, is to assess the midline structures. There is overlap between midline and cortical mantle abnormalities. However, assessment of the midline structures helps differentiate severe, lethal conditions such as hydranencephaly and alobar holoprosencephaly, and to subsequently narrow the differential. If the FOX is absent or deficient on ultrasound, then holoprosencephaly spectrum is most likely diagnosis. However, if the FOX is present, then determining if the cortical or cerebral mantle is intact is the next step, which distinguishes hydranencephaly from severe causes of ventriculomegaly, such as aqueductal stenosis. The next step is to confirm the presence or absence of the cavum septum pellucidum, also known as the CSP. The CSP is a box-shaped structure between the frontal horns on the lateral ventricles, best seen on the axial ultrasound images, and is a critical landmark of normal midline brain development. Absent CSP is associated with agenesis of the corpus callosum, schizencephaly, and lobar holoprosencephaly. First, let's discuss agenesis and dysgenesis of the corpus callosum, which both manifest with ventriculomegaly. Imaging features include parallel lateral ventricles with associated colpocephaly, a teardrop-shaped configuration of the ventricles with asymmetric enlargement of the occipital horns of the lateral ventricles. A steer horn appearance of the frontal ventricles can be seen on coronal imaging, with loss of the normal branching pattern of the anterior cerebral artery on color Doppler ultrasound. Absent cingulate gyrus and radial configuration of the medial gyri are noted on sagittal images. Note that the falx cerebri is present, however, depending on the underlying diagnosis, the appearance of the cortical mantle is variable. Next, we will briefly discuss AVID complex, which stands for asymmetric ventriculomegaly, interhemispheric cysts, and dysgenesis of the corpus callosum. Constellation of findings can be detected on ultrasound and are better characterized on fetal MRI. The falx cerebri is present with absent cavum septum pellucidum. There is associated asymmetric ventriculomegaly with greater than 50% difference in lateral ventricle diameters, and interhemispheric cysts, which may or may not communicate with an enlarged lateral ventricle, is detected, and there is associated dysgenesis or agenesis of the corpus callosum. Moving on to holoprosencephaly spectrum, which is the result of incomplete cleavage of the cerebral hemispheres in early embryogenesis. Severity ranges from alobar, most severe, to semilobar, to lobar, the least severe form. Alobar holoprosencephaly, the most severe form, is characterized by absence of the midline structures, including the falx cerebri, interhemispheric fissure, CSP, and corpus callosum. The mantle is fused anteriorly and the deep brain nuclei are also fused, with resultant malformation of the third ventricle leading to the development of a midline dorsal cyst. In the least severe form, alobar holoprosencephaly, there is some fusion of the anterior frontal lobes, although with separation of the posterior frontal lobes and more posterior structures, including the splenium of the corpus callosum. There is variable dysgenesis of the corpus callosum, however, the genu and rostrum are generally absent. The falx and interhemispheric fissures are absent anteriorly but present posteriorly. Finally, we will review the next step in anatomic evaluation when the cortical mantle is present but abnormal. Differential diagnoses include both developmental and destructive processes. Developmental, migrational, and abnormalities include lissencephaly, gray matter heterotopia, pachygyria, and polymicrogyria, versus a destructive process which can range in severity from focal porencephaly to hydranencephaly. Starting with lissencephaly, a developmental abnormality in which there are three types: type 1, 2, and 3. Type 1, or the classic lissencephaly, is characterized by complete agyria, which is absent gyri, or regional pachygyria, a few broad gyri, with subcortical band heterotopia, which is a layer of heterotopic gray matter ectopically located. Classic type 1 lissencephaly can be an isolated abnormality or be associated with Miller-Dieker or Norman-Roberts syndromes. Ventriculomegaly is variable in type 1 lissencephaly with an unknown incidence, likely secondary to the genetic heterogeneity. However, severe ventriculomegaly is typically seen in those with TUBA1A mutation. Early diagnosis is challenging and should not be suggested in fetuses less than 20 weeks gestational age, although it is easily seen on third trimester ultrasound and MRI with a smooth cortical mantle and lack of normal sulcation pattern for expected gestational age. Type 2, aka cobblestone lissencephaly, is characterized by diffuse fine cortical nodules, posterior fossa abnormalities, and ventriculomegaly. Walker-Warburg syndrome is a type 2 lissencephaly with a kinked Z-shaped brainstem. Now we will discuss gray matter heterotopia, an intrinsic error in neuronal migration which manifests as either periventricular nodular heterotopia or subcortical band heterotopia. There are more than 100 associated genetic and chromosomal abnormalities. It is key to assess the ventricular lining in any fetus with ventriculomegaly to detect ependymal nodularity. On fetal ultrasound, subependymal nodules can be seen lining the ventricular walls in a dot-dash pattern relative to the expected normal smooth ependymal surface. This finding is typically underdiagnosed given imaging limitations. This can be more easily identified on fetal MRI. The subependymal nodules follow the cortical gray matter signal intensity on MR, with a specificity of 100% if identified on two imaging planes. Differential diagnoses include gray matter heterotopia versus subependymal tubers associated with tuberous sclerosis versus adherent clot in the setting of intracranial hemorrhage. Lastly, we will briefly discuss ventriculomegaly secondary to underlying destructive process. The two main categories I will go into more detail regarding include hydranencephaly and encephalomalacia. Starting with hydranencephaly, which is near complete destruction of the cerebral hemispheres, secondary to catastrophic vascular injury, with an incidence of less than one case per 5,000 to 10,000 live births. Vascular injury results in brain liquefaction and resorption with replacement by CSF-filled sac in the anterior circulation, with preservation of the structures in the posterior circulation, including the posterior fossa structures, brainstem, basal ganglia, and parts of the temporal and occipital lobes. The falx cerebri will be intact, a helpful feature to distinguish this entity from alobar holoprosencephaly. MRI can be a helpful adjunct to assess for absent versus thin cortical mantle, which can be difficult to accurately diagnose on ultrasound secondary to fetal position or reverberation artifact from the skull. In contrast to the complete absence of a supratentorial brain parenchyma, encephalomalacia is incomplete parenchymal destruction from an insult or injury, which may be vascular, infectious, inflammatory, metabolic, or toxic in etiology. Parenchymal injury is typically periventricular in distribution, secondary to immature vascular supply to the cerebral white matter. Imaging patterns on fetal ultrasound include increased echogenicity of the ventricular lining, small anechoic cystic spaces within the periventricular white matter, larger cystic spaces within brain parenchyma with possible connection to the ventricular system without mass effect, which is also known as aporencephalic cysts, and ventriculomegaly. Ventriculomegaly is secondary to diminished brain volume and impaired CSF resorption due to interventricular debris and blood product. When a cyst is detected on ultrasound, it is key to always use color Doppler ultrasound to confirm avascularity of the porencephalic cysts and to avoid misdiagnosis of a vein of Galen malformation, a high-flow vascular lesion. Fetal MRI is a useful adjunct to better assess the brain parenchyma. T2 images best demonstrate areas of parenchymal destruction. Associated areas of hemorrhage will be T1 hyperintense and demonstrate susceptibility on GRE sequences. Diffusion-weighted images will show increased diffusion signal intensity with corresponding decreased signal intensity on apparent diffusion coefficient maps in areas of ischemia. Congenital infections, including torch infections, which stands for toxoplasmosis, other, rubella, CMV, and herpes, are also differential considerations when fetal ventriculomegaly is encountered. However, there is an overlap in imaging findings between various congenital infections, and diagnosis depends on laboratory testing. In conclusion, when fetal ventriculomegaly is diagnosed, both fetal ultrasound and MRI are complementary exams, and stepwise anatomic approach can be utilized with close attention to the posterior fossa, midline structures, and cortical mantle to help the radiologist narrow the broad differential diagnosis. Imaging assessment in conjunction with clinical testing for infectious or coexisting genetic or chromosomal disorders allows for optimal prenatal counseling and management.